recording of this, and then I'll share my screen. Hold on a sec. Okay, well, I hope you can all see that. Let me see. It's a bit confusing, isn't it? Okay, hope you can see my slides. Well, as I said, welcome everyone to Paediatric Teaching today. Today I wanted to talk about paediatric oncology or cancer in children, and it's a big topic, and you get a lot of throughout your training in the 5 years or so of your training, you'll get a lot of teaching on paediatric oncology, and in some ways you can't cover it all in 1 hour. We might stretch this over a 2 hour two hour lectures. I think see how far we get today. But I guess I just wanted to give you the basics of paediatric oncology so that you can build on that and read around the different paediatric cancers and learn a bit more about oncology and chemotherapy and the way we look after children who have cancer. So that's what I wanted to talk about today. First of all, I wanted to just hang on. Let me see if I can move my slides. Today it was a very sad day last week because we lost Dr. Magdalene Kauper, and some of you are very young, so you may not know Dr. Kauper very well, but Dr. Kauper was the Deputy Chief Paediatrician in the Highlands, a very committed paediatrician, a wonderful, she'd worked in the Highlands for many years, and I think she graduated in 2003 and worked in the Highlands for most of that time. She was a tireless teacher of healthcare workers, and you can see her there teaching on a course that we ran a few years ago, and so it's very sad to have lost Dr. Kauper, so in memory of her today, we'll talk about cancer. So the first step, I suppose, in understanding pediatric cancer is how to recognize it, and I've listed there just a number of common symptoms of pediatric cancer. These are typically the things that families bring their children to a hospital or to a doctor asking about and or complaining of, and what you'll see is that all of these things are relatively non-specific. That is, many children have pallor, for example, and they don't have cancer, but many children who have cancer present with pallor. And the same for easy bruising. You can have easy bruising from lots of different reasons, because you've got a low platelet count, or you've got coagulation problems, or any several reasons. Same with bone pain. That could be because of an infection in the bone, or it could be because of trauma, but it can also be because of cancer. Same with frequent infections. Lots of children get frequent infections, and that could be because of some immune deficiency or because of undernutrition. But children who have cancer often get frequent infections. Same with a lump. A lump could be an abscess, or it could be a, it could be a cancer. All of the swollen eye, proptosis, that's a protrusion of one eye. That could be because of an infection or an abscess behind the eye, or it could be because of cancer. So you can see that all of the symptoms that children present with are what we call non-specific. They could be cancer, or they could be something else. And the way to diagnose pediatric cancer, I think, is to be alert to the symptoms that could be cancer, and not always think that they are cancer, but just have that in your mind that perhaps they could be cancer. And after you've, that's why you need to do a full assessment of the child and consider other diagnoses, and then think, well, could it be childhood cancer? In some countries, they have quite good public or healthcare worker education programs to identify the early warning signs of cancer. This is from South Africa. I think it's a very good program, and it tries to teach healthcare workers and parents how to identify the earliest signs of childhood cancer, including like a white spot in the eye, or a squint of the eye, or a bulging eyeball, such as you see with a retinoblastoma, or a lump in any part of the body, such as in the abdomen or the stomach, or glands in the axilla or the groin area, weight loss, sore bones, and neurological signs. So all of these things, again, they might be caused by childhood cancer, but they could be caused by other things too. And that's why we need to be just alert to them. I wanted to talk about the commonest forms of pediatric cancer. And again, I'm not going to say everything about each of these, but just to give you an overview of the types of cancers that children have in PNG and in most countries too. This is I guess in order of the common conditions. So acute leukemia being the most common, then lymphoma. We'll talk a bit about retinoblastoma because it's more common in PNG than most other countries. We'll talk about chest tumors too, because we see a lot of children who have a whiteout of their chest on their chest x-ray, and we need to be able to identify which children have tumors and which children have much more common effusions or empyemas, okay? We'll talk a bit about abdominal tumors because some of the treatable forms of cancer are abdominal tumors, like a Wilms tumor. And we'll talk a bit about, if we get time, about cancer emergencies, because I think it's important that we know how to deal with the most urgent situations in childhood cancer. When you're a registrar, you need to be able to manage children who are being treated for cancer and know how to look after those emergencies. So that's a lot to get through, and we'll see how we go in the next hour. So to start with, I wanted to talk about acute leukemia because it is the most common pediatric cancer. And of those acute leukemias, then the most common acute leukemia is acute lymphoblastic leukemia. So leukemias are abnormal proliferations of the white cells. And as you know, the types of white cells are broadly divided into lymphocytes and granulocytes. Okay, lymphocytes and granulocytes. And the granulocytes can be divided into neutrophils and basophils and eosinophils as well. And the lymphocytes can be divided into T lymphocytes and B lymphocytes. Okay, but acute leukemias are any abnormal malignant proliferation of white cells. Okay, they could be lymphocytic leukemias, lymphoblastic leukemias, or they could be myeloid leukemias, like the myeloid ones are the granulocytes. Let's talk about acute lymphocytic or lymphoblastic leukemia. When I say blastic, that refers to the very immature forms of the lymphocytes. All right, before we develop mature lymphocytes, then there are lymphoblasts, and rarely do you see lymphoblasts in the blood. But if you've got cancer, then those lymphoblasts, those immature forms, are being churned out by the bone marrow and by the other cancerous origins and producing lots of lymphoblasts in the blood. All right, but acute lymphoblastic leukemia, ALL, is the most common type of leukemia. And that presents with all the problems related to having high levels of lymphocytes in the blood. And as you probably know, the normal lymphocyte count in the blood is somewhere between 5 and 10. But in acute leukemia, it can be 30, 50, 100, 300. Even I've seen up to 1 million lymphoblasts in the peripheral blood. And those children present usually with pallor. And the reason they present with pallor is because the bone marrow is full up of lymphoblasts, those cancerous lymphoblasts. And so there's not enough room for the bone marrow to be making red cells. They usually present with easy bruising and bleeding, or often present with easy bruising and bleeding, because that can lead to, because the bone marrow is full up with lymphoblasts, the cancerous lymphocytic cells, and there's not enough platelets. And so because of the low platelets, then children have early easy bruising or bleeding. And then because of they often have lethargy or anorexia, often bone pain, because the bones where the bone marrow is, and there's infiltration of the bones and the bone marrow with the lymphoblasts, with the leukemic cells. and that causes bone pain. So bone pain and reluctance to walk could be anything. It could be an infection, or it could be trauma, or arthritis, but it also could be leukemia. So when you hear of a child having bone pain and refusal to walk, especially with other chronic illness features like anorexia and weight loss, then think of leukemia. When you examine those children, they're always usually pale. They have a big liver and a big spleen, and that's because it's just full up with the leukemic cells. They sometimes have skin infiltration. So this boy has got infiltration, especially of the gums, and the infiltration of the mucosal lining of the mouth is common in some forms of acute leukemia. And about 5 to 10% of them, children with leukemia, have central nervous system leukemia because the leukemic cells have got into the brain. And some boys have leukemia of the testes as well. The leukemic infiltrates in the lymphoid tissue in the testes. And the reason why central nervous system and testicular leukemias are very important is because they're sites for which it's harder for the chemotherapy to reach. And so when you're treating these children, if they've got testicular leukemia or CNS leukemia, then you need to give them special medicines to make sure that you're reaching those, what we call sanctuary sites. They're sanctuary sites because the leukemic cells can hide in those areas and not be treated with the standard chemotherapy that's given intravenously or orally. Okay. Now, 80% of all acute leukemias are ALL, that is acute lymphoblastic leukemia. And most of those are what we call pre-B ALL. Pre-B ALL is most of the acute lymphoblastic leukemias. And the reason why we call it pre-B ALL is because, remember I said that the lymphocytes can be either T-cell lymphocytes or B-cell lymphocytes. And the reason why it's called pre-B ALL is because it's the precursors, the immature B-cell lymphocytes that have become cancerous and proliferating. T-cell ALL is seen a bit more commonly in adolescents, so older children, 10, 12, 14, that sort of age. And that makes up about 10 to 15% of the total leukemias, right? So 80% pre-B ALL. 15% are acute myeloid leukemia. Remember I said the white cells are either lymphocytes, and they can be B or T, and the other types of white cells are the granulocytes, and they make up the myeloid cell line. So neutrophils and basophils and eosinophils. And the most common type of granulocytic leukemia is acute myeloid leukemia, AML. Much less commonly is a form of chronic myeloid leukemia. Don't worry about that too much, but just know about, I think, ALL and AML and the types of ALL particularly. So this boy had AML, and you can sort of tell a bit. You can detect that it's more likely to be AML because he looks very unwell. He looks really pale. He's got some bleeding and gum hypertrophy. He just looks like he might have AML. When you look at the blood film of children with leukemia, this is ALL. You won't be used to looking at blood films, but you can see the lymphocytes. Look, there's lots of them in the blood film. These are the red cells, the normal red cells with the targets in the middle. And these are they're lymphoblasts. And lymphoblasts have very big nuclei. So this is the cell, and the purple is staining. The blue part is the cell, and the purple staining part is the nuclei. And these lymphoblasts have very large nuclei, and that's the way you can tell that they're lymphoblasts. They look different to normal lymphocytes. Children who have got ALL, there's various ways we can assess their prognosis. And it used to be that the higher the white cell count was at the time the child presented, and and the age of the patient dictated their prognosis. So very young patients who have leukemia, if you're under 1 year of age, that's not a good prognosis. Or if you're an adolescent, that's often not a good prognosis because of the type of leukemia that you have. It's more likely to be T cell. But that's changed a bit, and now we have more sophisticated ways of assessing prognosis, and some of those are looking at the chromosomes. And some of those are other things like measuring a response initially to chemotherapy, looking whether the child's got central nervous system and testicular disease. And then after the induction phase of chemotherapy, this is probably the most important thing, is after the induction phase of chemotherapy, working out whether the child is in remission or not in remission. And being in remission means that when you've had your induction chemotherapy, which usually goes for about a month, then doing another bone marrow and looking to see if the child's got what's called their MRD, which is their minimal residual disease. If they've got no detectable leukemic cells in their bone marrow after a month, then that's quite a good prognostic sign. But if they still have leukemic cells in their bone marrow after a month, then it means it means their leukemia hasn't responded properly to or fully to their chemotherapy. The treatment of acute leukemia, acute lymphoblastic leukemia, I've just outlined the basics of the treatment, and this is the most common type of treatment of leukemic treatment. There's other variations on this, but most children with leukemia receive, for 1 month, their induction chemotherapy is with vincristine, a variety of different chemotherapy drugs. So one is vincristine, daunorubicin, prednisolone, and asparaginase. That's the 4 drugs that are given for the first month. The main reason to sort of know at least the names of these drugs is that, firstly, at some stage during your training, you'll be giving chemotherapy, and it's important to know the names of the drugs, and also important to have some idea of their side effects. All chemotherapy agents, they're designed to interrupt the duplication of cells. And now, as you know, the cells, whether they're leukemic cells or any other cells, they duplicate by mitosis, and that's genetic duplication of cells. And the chemotherapy disrupts the normal mitosis of cells, the doubling of cells all the time. But chemotherapeutic agents, they don't just target the leukemic cells, they target the most rapidly dividing cells. And that's the leukemic cells are generally rapidly dividing. But there's also a lot of other rapidly dividing cells in our body, including, say, our hair. That's anything that grows and replenishes quickly. So hair, the lining of our mouth, or especially the lining of our mouth and our gastrointestinal tract and our skin to some extent. So that's why when children get given chemotherapy, their hair falls out, because the hair is rapidly dividing. Hair cells are rapidly dividing, and often they get ulcers in their mouth because of the we're always all the time getting small cuts or ulcers in our mouth or on our skin, but we have rapidly dividing cells. Oh, sorry, we have rapidly dividing cells. Are you getting a bit of feedback on? I'll just turn off my. Can you hear me? Okay.
Yes.
Okay, I'm hearing myself talk twice, but we'll see how we go. So yeah, chemotherapy targets rapidly dividing cells, and the cancer cells are the main targets, but the side effects we get from chemotherapy are often related to the other rapidly dividing cells that are in our body that are normal and normally rapidly divide. There's some other side effects from these chemotherapeutic agents, which we'll talk about perhaps when we have time. But vincristine, daunorubicin, prednisolone, and asparaginase. Asparaginase often causes, or sometimes causes, an inflammation of the pancreas. So pancreatitis can occur with asparaginase. And vincristine often causes a problem with the, it can cause a problem with the bowel. In fact, it can cause a bit of what we call autonomic neuropathy, where the bowel tends to not peristalse as well. These are all temporary complications, but children who are receiving vincristine and asparaginase can sometimes get these complications. So when we're giving chemotherapy, we need to be aware of that. After 1 month of chemotherapy, most of these children have a bone marrow to check if they've got what their minimal residual disease is, whether they've got a good response to chemotherapy or whether they've had an inadequate response. And then they go on to, if they've had a good response, then they go on to consolidation chemotherapy. And that's with often vincristine and methotrexate and prednisolone and another drug called 6-mercaptopurine. Again, you don't need to worry too much about the names of the chemotherapeutic drugs, but just know basically the phases of therapy. Sometimes during their early treatment, these children get intrathecal methotrexate. And remember I said that leukemia can sometimes involve the central nervous system and also the testis. And so these children receive intrathecal, that is methotrexate injected through a lumbar puncture, and they'll need several doses of that, usually about 4 doses of intrathecal methotrexate early on in their treatment. And then after that, their consolidation phase, they get often a reinduction, which is re-intensification using the same agents, vincristine, guanosine, prednisolone, and asparaginase. And then they go on to maintenance therapy, which lasts 2 years. I wonder if people could put themselves on mute if you could, so that I might just, if you could, Elena, would you mind putting yourself on mute? Because then, thank you. I'm not sure whether the feedback is because of that. Thanks. For children with acute leukemia, 95% go into remission. 95%. Okay, we'll try that. 95% of children with acute leukemia go into remission after their induction therapy, and about 80% of them are successfully cured with chemotherapy. So the reason why it's good to know about acute leukemia is that it has a high cure rate if you can do all of that over, but it takes up to 2 years, 18 months to 2 years of therapy usually. Now, I wanted to say something about differentiation of cells, because in understanding acute myeloid leukemia, we need to understand what the immature forms of the granulocytes are. And remember I said that lymphocytes can be B cell or T cell, and granulocytes, the other side, can be neutrophils or basophils or eosinophils. But the neutrophils, when they're in your blood, like we measure neutrophils in the blood, but there are earlier forms of neutrophils, which are usually the ones that become leukemia, right? And so sometimes we talk about acute promyelocytic leukemia, and that's when the leukemic cells are promyelocytes, or we might talk about metamyelocytic leukemia or myelocytic leukemia, and that's when the leukemic cells have arrested development, but then they proliferate as myelocytes or metamyelocytes or promyelocytes. And so when you think about acute myelocytic leukemia, AML, then there's a lot of different types of, there's many different types of AML. I'll just try to mute. Alina, you might just mute your Thank you. Yeah, there's many different types of immature forms that can become leukemic. All right, this is for AML. AML. Now, AML, as I said, is a cancer of the myeloid white cells. So myeloid means like, it's a bit like granulocytes. And I showed you a picture of ALL before. And remember in ALL, the nuclei were very large, but they were round. They were single circular nuclei. Well, these are AML cells, and you can see they're bilobed. The nuclei are bilobed, and sometimes they're trilobed as well. So these are myeloblasts like lymphoblasts, but you can tell it's AML because they're the bilobed nuclei of the AML cells. It's about 20% of childhood leukemias, so 80% is ALL, 20% is AML. And these children often present with some different features like coagulation problems and what we call DIC, or disseminated intravascular coagulopathy. They often present with easy bruising or bleeding, and they look very, very sick typically when they present. And they often, as I said before, they might have gum hypertrophy or bleeding from their gums or skin infiltration. They're more likely to have CNS leukemia than ALL. And their survival rates are a bit lower than ALL, but they're still pretty good with good chemotherapy. So at least 50% survival with good chemotherapy. So we've talked about acute leukemia, and now I wanted to talk about lymphoma because they're related to the leukemias, and but they're all lymphocytic. They're not granulocytic. Okay, the lymphomas are lymphocytic, and remember I said that lymphocytes can be B cells or T cells, and about 30% of the lymphomas are T cell in origin. And the types of lymphomas that are T cell in origin often typically occur in older children, so young adolescents can get T cell ALL. It can be a T cell lymphoma, and there's a relationship between T cell lymphoma and T cell ALL. So some children have both lymphoma and leukemia at the same time. They have a lymphomatous mass, often in their mediastinum, arising from their thymus, but they also have a lot of leukemic cells in their peripheral blood. So there's an overlap between T cell ALL and T cell lymphoma. And the other type of lymphoma is called B cell lymphoma. And that is the reason I mention this is because it's more common in PNG, and it's called Burkitt's lymphoma, Burkitt lymphoma. And Burkitt lymphoma makes up at least 70% of lymphomas in PNG. It's more common than T cell lymphoma. Yeah, I'll talk a bit about Burkitt in a little while. The T cell lymphomas come from the thymus. Remember, the thymus is in the mediastinum. So typically you have a mediastinal mass, and it presents at around about sort of 10 to 15 years of age. It can present earlier, but usually 10 to 15 years of age. And those children typically have a mass in their mediastinum, and they present often with, they may have been diagnosed with asthma, or they have some airway obstruction like stridor or wheeze. They sometimes have a pleural effusion, so people might think they have a pneumonia. And when they present, sometimes they have bronchial obstruction, or what we call SVC syndrome. Their superior vena cava is obstructed, so they might have swelling of their head because the superior vena cava drains the blood from the head. This is the way they typically present. These children have a lot of what we call mass disease. They have large mass disease. In fact, they have millions and millions of leukemic cells all arising from their thymus. And they're at high risk of this complication called tumor lysis syndrome. And that means when you give the first lot of chemotherapy to treat the child's leukemia or their lymphoma, then the cells die very quickly. And when their cells are dying, they release a lot of chemicals, a lot of electrolytes, and that can cause some major disruption. I'll talk about tumor lysis syndrome in a short while. This is a child who's got T-cell ALL. And what you can see from this X-ray is how you would look at this and you would say that the heart looks very abnormal, doesn't it? The lung fields look okay. There's nothing wrong with the lungs, but the heart shadow looks very abnormal. And what it is a large mediastinal mass overlying the heart. The heart itself is normal, but there's a large mediastinal mass in the upper mediastinum. And you can see it's filling in this, what's normally the retrosternal airspace is completely filled in by the mass. Usually you can see aeration of this area here, just like at the back, and but it's being filled up by this mass. But you can tell this is probably a mass of thymic origin. And if you see an older child with a swelling like this, it's almost certainly T-cell ALL. These children, as I said, when you start their chemotherapy, they're at quite high risk of getting tumor lysis syndrome. And the higher the white cell count and the bigger their mass disease, the bigger their mediastinal mass or the bigger their liver and their spleen when they first present, the greater their risk of tumor lysis syndrome. And often that occurs when you first give them their first dose of prednisolone or vincristine, and they get rapid lysis of cells. And when inside cells, there's a lot of potassium and phosphate, and there's all the genetic material like DNA, and that all gets broken down, and it releases uric acid and potassium and phosphate from the cells that are dying, the leukemic cells that are dying. And so the child ends up with hyperkalemia, very high potassium level, and often a metabolic acidosis because all the cells are dying, and often hyperphosphatemia, that is their phosphate level in the blood goes very high, and that combines with calcium, and you get very low levels of calcium in the blood. And so they're the common features after when you start treating these children with chemotherapy. They may get tumor lysis syndrome, and you can help prevent that by giving them, making sure you give them what's called hyperhydration, which is a lot of fluid, a large amount of intravenous fluid before you start their chemotherapy, usually for 6 or 12 hours before you start their chemotherapy. And you can also do some other things like giving them allopurinol and some other medications which can reduce the risk of tumor lysis syndrome. Sometimes children this is a boy who had tumor lysis syndrome, and he's got what's called tetany, which is a very low level of calcium, so that it's like seizures, but it's a particular sort of seizure, a bit like tetany if you've got tetanus. But these days we prevent that by giving hyperhydration and allopurinol, and sometimes we give a drug called respiricase. That's a more effective drug, and alkalinizing urine. But sometimes they get very severe hypokalemia or hypocalcemia or hyperkalemia. So their potassium goes up and their calcium goes down, and that's typically what happens. I wanted to talk a bit about Burkitt lymphoma because it's common in PNG, and it's a very important cancer because remember I said the lymphomas, you can have T-cell lymphoma, you can have Burkitt lymphoma. The other one is Hodgkin's disease. That's the other type of lymphoma. But Burkitt lymphoma is an important cancer because it is common in PNG. It's also the fastest growing human cancer. It's extraordinary how rapidly it divides and it increases in size. And these children present typically with fever and weight loss and night sweats, usually painless lumps in their lymph nodes. This boy is presenting with a Burkitt of the jaw, large submandibular lymph nodes and lymphadenopathy. It's not clear what the exact reason why Burkitt is so common in PNG, but it probably relates to its association with a few viruses and other infections. So it is associated with particularly Epstein-Barr virus, which is relatively common, another virus called HHV8, so human herpes virus 8, and also has some association with HIV, although not directly associated with HIV, but EBV particularly associated. In fact, Burkitt lymphoma was first described in PNG. The first time in the world it was described was in PNG, and also in Africa, where Burkitt lymphoma is more common too. So there is some connection between infections, malaria, and Burkitt lymphoma. It typically produces, there can be a Burkitt of the jaw or of the lymph nodes or of the gastrointestinal tract. So Burkitt lymphoma can involve, it can be a gastrointestinal Burkitt, or sometimes you can get spinal cord compression with spinal Burkitt lymphoma. These children also present with pancytopenia, that is, they're anemic, their white cell count is low, their platelets will often be low. They often have a raised uric acid because, remember I said when you start treating these patients, their cells start lysing and they release uric acid, they release potassium, and they release phosphate as well. Well, some of these children with Burkitt, their cells are already turning over so quickly that some of them are dying even before the chemotherapy, and so you have a lot of uric acid in the blood. There is a genetic predisposition to Burkitt lymphoma that maybe increases the risk of having what is called the African type of Burkitt, which is like this, a Burkitt of the jaw. There is another type of, this is called the endemic Burkitt lymphoma because it's quite common in many countries in Africa, like it is in PNG. And then there's what's called the sporadic Burkitt lymphoma, which we see less of. It's sometimes called the American type because it was described in America, and it's typically more typically affects the gastrointestinal tract and the para-aortic lymph nodes in the peritoneal cavity. But it's this type, the African type or PNG type of Burkitt, that affects the jaw, which is probably the most common, or affects the lymph nodes. As I said, there is a relationship, I won't go into it too much, between Burkitt and malaria. It's more common in holoendemic areas in PNG and in Africa, but it also occurs, Burkitt lymphoma also occurs in highlands PNG. There were some studies that were done showing that it accounts for about 16% of childhood malignancy, so it's quite a common tumour. And the typical age was a child of 6 years of age, more common in males than females, 8 to 1, quite a lot more common in males than females. And more than half involved the facial structures like the jaw or the submandibular region. I won't go into the origin of it, but there is some relationship, as I said, with malaria and EBV and this genetic predisposition, this c-Myc proto-oncogene, which predisposes to Burkitt's lymphoma after EBV infection in children who are living in malarious areas where perhaps they have some immune suppression because of chronic malaria. So it's possible that chronic malaria leads to immune suppression. The child gets EBV, they have a genetic mutation, this c-Myc proto-oncogene, and they get an EBV infection, and then they get Burkitt. That's probably the origin of Burkitt lymphoma. It's an interesting cancer because it has an unusual origin. But as I said, it's a very rapidly growing tumor, so you have no time to waste in treating these patients. This is an abdominal Burkitt lymphoma, what they call the non-endemic type of Burkitt. You can see the large mass in the abdomen. It arises from the Peyer's patches in the gastrointestinal tract. The Peyer's patches are like the lymphatics. They're like lymph nodes in the gastrointestinal tract, which also, of course, can be the origin of TB. That's where you often get abdominal TB. That's an abdominal Burkitt. The characteristic feature when you do histology is what's called a starry sky histology. I think I sort of like this, histopathologists like to just talk about starry sky look of a Burkitt lymphoma, and it looks a bit like this beautiful painting by Van Gogh called Starry, Starry Night. That's the characteristic feature of a Burkitt lymphoma when you do a biopsy. There's no time to waste in treating these patients because they rapidly progress, but they also can often be treated quite well. Often there's a high cure rate for Burkitt lymphoma if you get it reasonably early. And the treatment that's been given for many years is what's called CHOP. It's a cyclophosphamide and four chemotherapeutic drugs: cyclophosphamide, doxorubicin, vincristine, and prednisolone. And the reason why it's called CHOP is because these drugs have other names: cyclophosphamide, doxorubicin, oncovin, which is the same as vincristine, and P for prednisolone. But it's also called CHOP because it was first of all described at the Children's Hospital of Philadelphia. That's why it's called CHOP, Children's Hospital of Philadelphia treatment for Burkitt lymphoma. These days there are other medications that are sometimes used in Burkitt lymphoma, but the cure rate from CHOP is moderately good. So if you can start early, then some of these children have a good prognosis. These children often get tumor lysis syndrome, so you should expect it when you start their treatment. I wanted to talk a bit about retinoblastoma. And the reason why I want to talk about it again, a bit like Burkitt, is because it's a more common tumor in PNG than it is in other countries. It's quite rare in many countries, but not so rare in PNG. And it's also a tumor that it's good to, like, often, sadly, we see children who look like this. By the time they present, they've got marked proptosis and they've got a spread of the retinoblastoma into the bone. You can see there's swelling of the bone, and they've got a sort of hemorrhagic sort of proptosis. So the tumor, the retinoblastoma, has gone a long way. It's spread a long way. And we should be trying to pick up these patients with retinoblastoma a lot earlier. Most of them are young children, and they won't always, it won't be easy to see. They usually don't complain of like eye pain or anything, but the earliest signs are not something like this. The earliest signs are that they might get a squint. By a squint, I mean disconjugate gaze of their eyes, or one eye, a turned eye, if you like. So a squint is often the earliest sign. Or they might have nystagmus. Their one eye, when they're moving their eye to the side, it flickers. Or they might have what's called, the most important sign is what's called leukaemia, and that's a white reflex of the eye. Instead of having a red reflex, they have a white reflex because they've got a mass of the retina that's normally the retina, when you look at it with the light, is red. If you look at it with fundoscopy, the retina looks red. But when you look at the eye of a child who's got an early retinoblastoma, they have a white reflex instead of a red reflex. I'll show you a picture of a child with a white reflex in a moment. Most of these children are under 5 years, or all of them are under 5 years, and most are under 3 years. Some of the retinoblastomas are inherited, or they're hereditable. That is, they typically come from germline mutations. That's mutations of the egg or the sperm in the retinoblastoma gene. So they're not like systemic total body mutations. They're mutations of just the egg or the sperm, what we call germline mutations. And they're the hereditable ones, and they're often bilateral, right? And so unfortunately for some children who've got retinoblastoma, that if they have it in one eye and they have the hereditary form of retinoblastoma, there's a high risk they're going to have it in the other eye. And of course you can, if you lose one eye, you can still function pretty well, but if you obviously it's an awful thing if a child goes blind. But that's the case for some children. The non-hereditary forms of retinoblastoma usually aren't bilateral, but the hereditary forms often are. This is what I mean by a white reflex. And this is a child who has, you can see instead of that red reflex that you see sometimes when you take a photograph of a person with using a flash from a camera, you see the red reflex. Well, this is a white reflex. This is a child with an early retinoblastoma, which is the sort of, time it would be good to be picking up these patients. Often they have a squint or a white reflex of their eye, and these patients can do very well if you catch them early. The therapies depend on the extent of the spread of the tumour, and it can be local or systemic chemotherapy. Sometimes other forms of cryotherapy or laser therapy for the tumour. And sometimes it's spread so far they have to have a nucleation of the globe, a nucleation of the total eye, and really their prognosis depends on spread. If it's spread to bone, the prognosis is very poor. But if it's just isolated to the retina, the prognosis is better. But if the whole globe is destroyed, then the prognosis is poor. But the therapy depends on the extent of the tumour. And for some of these children that you see early, they can have a good outcome. Okay, I might just talk about chest tumours, and then we might stop for today because we've talked about a lot of things. The reason I'll talk about chest tumours now is because some of what I've said about lymphomas overlaps with other forms of chest tumours. So I've talked about tumours of the chest that are lymphomas, like T-cell lymphomas, and also other tumours can arise from the thymus, like a thymoma. That's not a thymoma is a different form of cancer to a T-cell lymphoma, but it arises from the same organ. Thymomas are much less common, but they sometimes present with generalized weakness, like they may present with myasthenia gravis. The other common chest tumour that children can have is one that arises from if you think about all the things in the chest, there's the sympathetic ganglion or the sympathetic nervous system, and that's a neuroblastoma, and that arises in the posterior mediastinum. It sometimes arises in the abdomen as well, but typically in the posterior mediastinum. And then there's other structures inside the chest, such as muscle or bone, where you can have a tumour of muscle is called a rhabdomyosarcoma, or a tumour of bone is called an osteosarcoma. So rhabdomyo, muscle meaning muscle, and the rhabdoid muscle, rhabdomyosarcoma of muscle, or osteosarcoma of bone. And then there are some other forms of tumours that are germ cell tumours, like germ cell in origin, and they're what's called teratomas. And so they're all the types of tumours that can occur in the chest. But the first step is trying to identify that something that occurs in the chest could be a tumour. And I've talked before about we see a lot of children who have like a large whiteout of the chest. So you look at it and you think, whoa, this child's got a big effusion, because this is all white, a big effusion. It's all white, and the mediastinum is pushed over to the right-hand side a bit. And you think, well, maybe there's just a big effusion there. Remember I said that there's 4 types of whiteout of the chest. One is an empyema or an effusion. Four things. One is fluid. It could be just fluid. The other one is consolidation, like pneumonia. The other one is collapse. That'll also give you a whiteout. And the fourth one is a mass. And the mass is the least common. But when we're thinking about what a whiteout of the chest could be, don't forget that a mass or a tumour, it could be. If it's fluid, it could be an empyema or a fusion or blood or lymph. But and this child's obviously got some fluid there. There's what we call a meniscus sign. There's obviously some fluid, but what you don't appreciate perhaps easily from the X-ray is that there is also a mass here. So it could all be fluid, but there's a mass underlying it. And this was evident. This is the same child. And I'll just show you this child's CT scan. And there's some fluid down here, but there's a big mass here. This is the chest tumor shown up on the CT scan. There was fluid around it because tumors often produce fluid. But you can have fluid because of an effusion from a pneumonia or TB, or you can have fluid because there's a tumor producing fluid. And so the trap sometimes is that these types of patients, that they may get a chest drain or they get treated with antibiotics and you think they'll get better, but they don't get better. And instead of thinking, is this a mass, they go on to TB treatment, and then they spend weeks or months being on TB treatment. And in fact, what they've got is an underlying mass. So if there's an uncertainty, I suppose, as to why an effusion's not getting better, then you should think, well, could it be a chest mass? And this is a chest tumor that's producing fluid. Yeah. This is the same. Another, you look at this and probably you'd say, well, it's an empyema or an effusion, and most likely it would be because that's much more common. I probably see 10 of these for every one chest mass, but still you've got to think, well, could it be a mass? Right? Start off thinking it's an effusion, but could it be a mass? And this is the same child I just showed you here, and this is the fluid. Yes, there is fluid, but there is a mass as well. This is not just the heart. This is a mass overlying the. Here's another one that you'd look at the X-ray and you'd say, it looks very strange, doesn't it? There looks like there's a white out of the left chest, but there's some strange opacities throughout it. And this is when you see this, it looks like lots of different types of tissue. And this is what's called a teratoma. And teratomas, remember I said they come from the germ line, so they can produce any sort of fluid. They can produce cartilage or bone or skin or hair or teeth, and sometimes you get inside a teratoma, you'll get pieces of immature bone or cartilage, or and that's why it gives such a what we call a variegated or heterogeneous appearance to the chest mass. Don't worry about that too much, but maybe the main message is that mostly an X-ray that looks like this will be an effusion or an empyema, but it could be a mass. And I think the key is it could be effusion, empyema, TB, or it could be a mass. And it's just worth keeping that in your mind. This is, as I said, a teratoma. It's a large tumor. Usually when you treat a teratoma, they have quite a good outcome. They need surgery, though, at some stage and to remove the tumor. But they typically have a good outcome because they're relatively slow growing, and they're often relatively benign tumors. Not completely benign, but benign. Teratomas, as I said, come from the germ cell origin, and this is another type of teratoma. It's called a sacrococcygeal teratoma, and this also is more common in PNG. And these, if you catch these early, and usually they're evident often when the child sometimes when the child's first born, and sometimes they present a bit later. This was when the child was first born, a sacrococcygeal teratoma. Obviously, you'd imagine there would be difficulty in delivering a child like this normally, and sometimes they get obstructed labour. But if these are treated early, they're often benign. This baby had his sacrococcygeal teratoma removed surgically, and then there was a repair of the perineal area, and did perfectly fine. There was no malignant spread of the tumor. So they can have a good outcome if you identify them early. These germ cell tumors often have what we call tumor markers, so you can measure their beta HCG and their alpha fetoprotein, and usually they're quite elevated. Yeah. Okay. Look, I think we might stop there, and we might finish this. Let me just see how far I've got to go. Yeah, we might stop there today because we've talked a lot about different tumours. I think the next time we might talk about other forms of childhood cancer, and it might be better to just stop there today. I'm happy to answer any questions that you might have, and we'll do the second part of paediatric oncology the next time.